Welcome everybody to the Developmental Disabilities Administration Choking and Dysphagia Train the Trainer course. Part 1, which is covered now, is entirely online and self-paced and must be completed in order to register for Part 2 of this training course, which will be held in person. So welcome, I'm Christina Kubasdal-Meeks, speech language pathologist with Rehabilitation Services Incorporated. RSI was created to provide an integrated multidisciplinary program to evaluate and treat individuals who have injuries, illnesses, or disabilities. At RSI, we provide occupational therapy, physical therapy, and speech language pathology services. I have been an SLP for over 22 years, worked in a variety of settings, including hospitals, adult daycare facilities, acute care settings, and currently our outpatient clinic, and have multiple certifications related to swallowing disorders. So coming to you today with information related to swallowing challenges, and with hope to share information about how to manage those challenges, and in some instances be able to prevent those challenges as well. So why do we need this training? In 2005, 2009, and in 2012, MDH issued findings from the Mortality Review Committee that concluded that a significant number of preventable deaths of individuals with developmental disabilities occurred due to inadequate staff supervision during dining, improper food preparation, or a lack of recognition that a swallowing problem could be present. So during this part 1 of this course, you are able to work at your own pace. All learning assessments in this part 1 are a prerequisite for enrollment in the in-person Train the Trainer course. So who should attend this training? The training is required under COMAR 10.22.02.11c, as well as COMAR 10.22.05.02b, for staff working with people with an identified swallowing disorder, in order for an altered textured diet, and/or a behavior plan that addresses eating behaviors. The training is required for current staff and new staff entering employment, and is strongly recommended for all staff working with individuals with developmental disabilities. During this part 1, we will cover topics that include what is dysphagia, the process of swallowing, a review of aspiration, choking and dysphagia risk factors, altered consistency diets and thickened liquids, as well as some safer eating strategies. So let's talk about dysphagia. What is dysphagia? We'll define that for the purpose of this course as a condition of having difficulty swallowing. Others might say dysphagia. It all means the same thing. When we talk about choking, we talk about severe difficulty in breathing because of a constricted or obstructed lack of air or issues in the throat. Some key terms that we want to keep in mind that will be used during this training include bolus, which is chewed food that while in the mouth is mixed with your spit or your saliva. So that mass of food mixture with saliva is called a bolus. We'll refer to a missed swallow as the occurrence of when food goes down the wrong pipe. I'm sure we've all had those instances where we cough or we choke and everybody says, "Are you okay?" And we say, "Yeah, it just went down the wrong way." That's what we'll refer to as a missed swallow. Aspiration is when that bolus, whether it's solid food or fluid, enters the lungs. And then we'll talk about penetration as well as the situation when food or fluid get to the level of the vocal folds, but a person has an intact reflux and they're able to otherwise cough or clear their throat, bring that material back up and send it then back down to the correct pipe. So some complications of dysphagia include choking, like we were talking about, coughing, a missed swallow, aspiration. Repeated aspiration could possibly lead to an aspiration pneumonia, which is an infection in the lungs that was caused by aspiration of a bolus. Unexplained weight loss, dehydration, because the individual is not getting enough fluid to their entire body, and in some cases, additionally and unfortunately, death. So dysphagia is quite common, to the tune of 15 million Americans carrying the diagnosis of dysphagia. But as it relates to the work that we do, it's very important to understand and recognize that of the individuals residing in nursing homes, approximately 50 to 75% of those individuals carry a dysphagia diagnosis. So in some way, shape, or form, they have struggle or challenge swallowing. 65% of the intellectually and developmentally different population also have dysphagia. So significantly more than half of the individuals that we're working with are going to be the topic of conversation during this first part of the course. 33% of individuals in a rehab hospital, as well as 15% of those in acute care hospitals, are diagnosed with dysphagia. So we want to recognize that there are top conditions linked to preventable deaths of people with intellectual and developmental disabilities, we'll refer to as IDD, in congregate care settings or in community-based residential settings. So those top 5 conditions include aspiration, include constipation or bowel obstruction, seizures, dehydration, sepsis, as well as gastroesophageal reflux disease. So how do these deaths that we're concerned about in our state occur? A couple different possibilities. First of which are mealtime behaviors. So during the course of the meal, perhaps a person stuffed too much food in their mouth, didn't swallow in between putting bites of food in their mouth, and then the food became so large of a bolus that it became lodged in their throat. In other instances, the person was known to have a swallowing disorder and or aspiration, and despite the proper feeding techniques and despite the proper food, diet, liquid preparation, the person aspirated. In other instances, the food or the liquid wasn't prepared correctly according to the doctor's orders. For instance, a sandwich was cut into quarters, so into 4 pieces, rather than quarter-inch bites as ordered, which will, as we'll learn in this course, represent a huge challenge for that individual. In other instances, the individual was consuming high-risk choking foods, so foods that become very hard to chew, very hard to swallow because of the viscosity of the nature of the food that we're consuming. So think about a peanut butter sandwich and how hard that often is to move around in the mouth and then to otherwise swallow, especially if we don't follow it with liquid. And then finally, in some other instances, there was no known swallowing problem, and death unfortunately occurred when someone choked while they were eating alone. All right, time for a knowledge check. First question, true or false? Dysphagia is defined as a condition that makes swallowing difficult or renders one unable to swallow. Answer is true. Next question. Which of the following can be a complication of dysphagia? Is it a wet, gurgly voice during or after meals? Aspiration? Avoidance of certain food or drink? Unexplained weight loss? Or are all of the above potential complications of dysphagia? Answer is all of the above can be a complication of dysphagia. Of note, we want to make reference to the idea that the individuals that we're working with, our IDD population, know themselves quite well and they know their limitations at times. Other times they don't know their limitations, but oftentimes they're savvy enough to recognize that there's a particular food or drink or set of food or drinks that are hard for them. And so if something is hard or uncomfortable, then most humans tend to avoid those situations. And so that explains why C, avoidance of certain food or drink, can be a potential complication of dysphagia. Individuals choose not to engage in that what is harmful or uncomfortable for them. And by proxy then, if individuals are avoiding certain patterns of food or drink, and then they are unable to meet their nutritional needs, unfortunately, then we run into a situation where they may present with unexplained weight loss. Next question. Which of the following is not one of the top conditions linked to preventable deaths of people with IDD in congregate care settings or in community-based residential settings? Aspiration, dehydration, pica, constipation. Answer is pica, eating things that are not food items. Okay, so let's jump into the science of the swallowing process. So what you have here in front of you is a representation of an individual from a side view, where the blue tract is where an individual can consume air. So two different points of origination, one through the nose, one through the mouth, coming down, merging at a certain point in the throat area with that red tract, and then you'll see they go in separate routes. So let's talk about that blue tract. Air comes in through the nose, through the mouth, and then goes towards the lungs. So in this picture, kind of the more forward, the front track, as we'll refer to it. And then food comes in through the mouth, goes to the back of the mouth, down the throat, so the back tract, and then goes down into the stomach. You'll see that there's an area of convergence where food and air meet each other in a very close proximity, but the ultimate destination for those two tracts being where air goes to the lungs, food goes to the stomach, and the hope and the expectation is that food does not go into the lungs. The process of swallowing involves the interaction of more than 20 muscles and several nerves and is incredibly fast. Whole process that involves mouth, throat, lungs, and stomach is completed in several seconds. So 3 phases to the swallow, the first of which is what we call the oral phase. So in the oral phase, we take a bite of food, we chew it. That food is mixed with our spit, our saliva, and is then turned into a bolus. Once the bolus is created in the mouth, we move that bolus from the front of the mouth to the back of the mouth towards the throat. And then we will work on initiating the second phase of the swallow. Of note here, we want to again look at the idea that the air is entering through the nose, could also be entering through the mouth. And here on your diagram, you'll see this green mass, that's your bolus. So the food's entering the mouth, gets chewed, moves to the back of the throat. That's the oral phase of the swallow. Let's talk about some challenges in the oral phase that are quite visible for us working with the IDD population that could indicate that there could be challenge for the individual in the oral phase of swallowing. Things that you might see that could indicate challenge include spillage of food from the mouth, out of the sides of the mouth, down on the chin. Perhaps the individual has a poor lip seal. So the most successful and easiest way to move a bolus from the front of the mouth to the back of the mouth is to close the mouth so that we can obtain the appropriate intraoral pressure to move that food backwards. If the individual has trouble wrapping their lips around a straw or closing their mouth during the swallowing process, then we're going to see that anterior spillage of the bolus potentially. Additionally, we may see what we call pocketing of food, especially if the individual is not taking sufficient swallows between bites. So individual may stuff or hold food under the tongue, may attempt to hold food in one or both cheeks, as well as in the area of the lips as well. And then last but not least, a little bit more challenging to visualize, individual may have trouble moving food side to side in the mouth or otherwise moving that bolus around to help them get it more posterior in the mouth. So that is the first phase of swallowing, the oral phase of swallowing. Once that bolus, so in this diagram, halfway through the second phase, but in your first diagram, it was up here, and we moved it to the back of the mouth. Once the bolus hits a structure back here called the fascial pillars, the individual loses volitional control of that swallow. So everything that happens in the oral phase is absolutely within my control for a neurotypical individual. Once that bolus hits what we call the fascial pillars, we no longer have volitional control of the swallow, and the body takes over command and control of that swallow, thereby initiating the pharyngeal or the throat phase of the swallow. What happens in this phase of swallow? Food enters the throat, the swallow is initiated, the epiglottis, a little flap that's back here, closes over the airway in hopes that the food follows down the tract to the stomach. Our Adam's apple, our larynx, moves up, and the vocal folds close tightly at the top of the airway. Again, another set of safeguards to prevent the bolus from entering the lungs. And then at the end of the pharyngeal phase of swallowing, the hope is that the food is entering the esophagus, thereby starting the third phase of the swallow. Challenges in the pharyngeal phase of swallowing are typically not as visible to those that are observing an eater. We may see some evident signs of challenge in the pharyngeal phase that look or sound like coughing or choking. If things go the wrong way, there may be some visible signs of challenge that look like watery eyes, red eyes, in addition to that cough or choke. One of the most visible ways to see if a swallow has at least been attempted to initiate is this notion that your Adam's apple will move up. So if we try to swallow, this area, especially prominent in men, more challenging to see in women, things will move up and then come back to rest. And that's an indication that at least a swallow was attempted. So that is the second phase of swallowing, called the pharyngeal phase. And then the third and final phase of swallowing is called the esophageal phase, or the phase that involves the stomach. So in the esophageal phase, food is moved down the esophagus by rhythmic muscle contractions, otherwise known as peristalsis, into the stomach. If food enters the stomach and doesn't come back up, then we consider that swallow to have been successful. Okay, so in a normal swallow, what you have in front of you in these diagrams will move from the top left to the top right, bottom left to the bottom right, and whereby in the other photos or diagrams the bolus was green, here it's blue. So again, you have a sideward representation where this is the nose, this is the mouth, these are the teeth, here's the bolus sitting on the tongue. So in top left, you have the food or the liquid that has since mixed with the saliva, and the individual's working on moving the bolus from the front of the mouth towards the back of the mouth, often referred to as the beginning of the throat. And we talked about the fascial pillars. When we move over here, we see that the bolus is moved up. The epiglottis is going to close over the tract to the lungs, and the bolus is going to start making its way into the throat. Bottom left now, here's your bolus again with the epiglottis closing over the tract to the lungs, and the bolus starting to come down to the tract to the stomach, which is what is happening here. So how do we know that a dysphagia is present? A couple of different ways. If there's suspicion of some swallowing challenges, oftentimes individuals who are working with the person who is having swallowing trouble will indicate challenge by virtue of observations that they're making of an individual, be they food avoidance or food struggle. Many of those oral phase challenges that are visible, food seems to be coming out of the mouth. The individual can't close their lips around food, whatever the situation is. And so depending on the site and the severity of the challenge, then the next steps will typically be an order from a physician for a variety of swallowing assessments. The first of which, and the least invasive, is what we call a bedside swallow evaluation, otherwise called a non-instrumental assessment of swallowing, or just a clinical swallowing exam. These exams are usually conducted by a speech-language pathologist, and what we do in those situations is ask the individual to swallow a couple different types of foods and or beverages based upon what information we've been provided and what we think is safest for that individual. And we'll do a host of things depending upon the situation that include watching the individual consume the food and making determinations about the safety of the food being swallowed, as well as the patterns that we observe during the swallow. Does the individual move food around in the mouth? Does the individual seem to initiate a swallow as promptly as we would expect? Is the process of chewing challenging? Does it take a long time? So we're looking at speed or timeliness, we're looking at effectiveness of the swallow, and we're looking for signs or symptoms of aspiration or penetration as indicated by the Adam's apple moving up, by whether or not there's any leftover food or beverage in the mouth after the individual tells us or otherwise indicates that they're done with the swallow, and looking at outward signs, coughing, choking, throat clearing, watery eyes, things like that, to give us indication as to whether or not, by and large, that swallow was successful and that food and beverage ended up in the stomach. If during this non-instrumental assessment of swallowing, it looks as though the individual is having great challenge, we may at that point modify the diet with what we presume based upon our experience and knowledge to be safest for that patient. Or there could be a whole host of situations that make us think that there's more to learn and more necessary information to be had about that individual, and so we'll send them for an instrumental assessment of swallowing, two of which we'll talk about now. And those types of assessments are usually completed either in a doctor's office or at an outpatient radiology department at a hospital, but they allow us more information than we can otherwise see during the bedside swallowing evaluation. Helps us be more informed, more thorough in our assessment, to make sure that we can provide the best recommendations for the individual's best safety for nutrition that's had by mouth. So if the clinical swallowing exam yields insufficient information, or again, one other outcome is that an individual looks like everything is being swallowed fine, but in fact what they're doing is not showing signs of aspiration or penetration despite that happening, we may request an instrumental assessment of swallowing as well. So the first of which is called a modified barium swallow study. We like to refer to it as a live x-ray. So individual is taken to a radiology department, and typically the radiologist along with the speech pathologist will position an individual on the x-ray table, and we will again provide food that they are to consume. We add barium to the food and we ask them to consume it, and we watch what happens at two of the three phases of swallowing, typically in a modified barium swallow study. So we'll watch what happens at the oral phase of the swallowing, we'll watch acutely what happens in the pharyngeal phase of swallowing, and make determinations about the safety of the swallow, possible modified diet, and liquid recommendations based upon where the bolus is going and how fast it gets there. So we are in live time able to watch and appreciate whether or not penetration or aspiration is occurring with a variety of food textures during a modified barium swallow study. In other instances, if a modified barium swallow study is not feasible, or we believe that we could get just as much information in an in-office assessment, then we'll utilize a different type of instrumental assessment referred to as a fiber optic endoscopic evaluation of swallowing, acronymed FEES. And In that instrumental assessment of swallowing, the doctor places a flexible endoscope with a video camera attached to the end, either through the nose or through the mouth. And then the individual is again asked to consume food and drink, and we'll watch what happens internally during the process of the swallowing to make informed decisions about the necessity and safety of modifying the individual's liquid and solid consumption. Last but not least, we can involve the gastroenterologist, and oftentimes it's that GI physician that is looking at the third phase of the swallowing, the esophageal phase of swallowing. So speech pathologist, radiologist, very involved in the oral and pharyngeal phase of the swallowing, and oftentimes it's the GI physician that's involved in the evaluation of the esophageal phase of the swallow. Okay, so let's put this knowledge into play and walk through what a modified barium swallow study looks like in the setting of a normal swallow as well as an abnormal swallow. So we'll try our best to pause through these videos, walk you through what you're seeing when you're seeing it. In the first video that we'll play, we're going to look at a normal swallowing. So same thing, you're looking at an individual from a side view where you can see their mouth, their teeth, and their soft palate up here. The relevance of these white structures is what we are referring to as the front tract versus the back tract, right? So right here is the front tract. This will lead down to the lungs. You can almost see a little bit of a separation. And in this back tract, this is where food we hope is going, and it's going down to the stomach. So as we said, process of swallowing is a very quick process, involves 20 muscles, many cranial nerves, and happens nearly instantaneously in a normal situation. The normal swallow will play, then we'll watch an abnormal swallow. What we're going to see in this situation is, again, you're looking at the teeth. We don't want the food to come forward. And in an abnormal swallow in this video, what you're going to see is food that does come forward, showing us what a bolus looks like that's being aspirated, as well as simultaneously coming down the tract to the stomach. So we have an individual that's not aspirating all of what they're putting in their mouth, but definitely a good portion of that. So here we go. We'll talk through what we see. Okay, so as we talked about, this arrow is going to show you where food is going to enter the stomach. So we're going to watch. So right here, that's a great place to show us. This is the bolus going down that back tract. And as we said, it happens super, super fast. So we'll kind of back up really quick for you. This is the bolus right here, individual chews. So now the bolus is over the tongue, it's moving backwards, and it's going to come all the way on that back track and come down, and the swallow is complete, just like that. Okay, so now in our second video, we're going to see the bolus over the tongue, and then we're going to see a little bit of it come down, but not all at once. And as the individual's still chewing, still moving the tongue pretty substantially, we're going to see a little bit of it slip down the throat before the individual is actually ready to initiate that swallow. Some of the bolus is going to come forward, indicating penetration, then aspiration, while the rest of the bolus comes down into the stomach. And here it comes. So the individual puts in what I presume is liquid. So the bolus is here. And there we load up. It gets out of their control. So some of the bolus is still in the mouth. Some of it is pooling in what we call the piriform sinuses and the vallecula. Individual tries to catch up with it. The bolus comes a little bit down into the back tract for the stomach, is still pooling here, but the bulk of the bolus is still in the mouth. We try to initiate a full swallow. So we've got bolus all the way from the mouth down into the level of the throat, the vallecula, the piriform sinuses. And now we can see we've got bolus in the mouth, in the piriform sinuses and vallecula, trying to come down to the stomach, but now also very much going into the lungs here. And so we swallow again, and you can see that we've aspirated. We've now individual swallowed at least twice, initiated. We still have leftover bolus up here. We still have leftover bolus over the tongue. We've mostly cleared what has gone into the stomach, and what went into the lungs is not, in this case, going to come back up and go down the right tract. That is our review of the swallowing process. So, in instances of aspiration, remembering that aspiration is the situation where the bolus passes the level of the vocal folds and moves into the area of the lungs, what will we see in the setting of a non-instrumental assessment of swallowing? Any or all of these. They don't have to all occur. One single symptom is enough to heighten our alertness, cause for concern. Behaviors like a gurgly or a wet voice after the swallow, and that could be immediately after the swallow, that could be minutes after the swallow. In some instances, it could be hours after the swallow, because remember in that video we saw there was some pooling of the bolus. If that doesn't end up being recognized by the individual, they don't clear their throat and then re-swallow, that pooled bolus can sit there for quite some time and continue to trickle down, causing a gurgly voice, again, minutes or hours after the meal or the swallow. We may see a runny nose. We may actually get full nasal regurgitation where the food or the beverage comes back out the nose because that soft palate didn't close sufficiently enough. Food came into the mouth and instead of going down, came back up. We may see red or watering eyes. The individual might complain of swallowing difficulty or challenge. Again, there may be unexplained weight loss. Individual may experience frequent pneumonia, and at that point, when there are multiple iterations of pneumonia, we start to wonder if the cause of that pneumonia is not necessarily just or at all viral or bacteria, but rather related to aspiration. Again, complain of swallowing difficulty or active avoidance of a particular liquid or solid. And as we already shared, aspiration can unfortunately be silent. It can happen without us knowing it all because the individual doesn't have intact reflexes and there's no visible or audible signs of swallowing challenge at all. And as we showed you, so aspiration on the modified barium swallow study looks just like that. Okay, so we'll hop back, but that's actually a great spot to pause where you can very clearly see. So this is the throat, this is the spinal cord, the individual is hunched just a little bit, but we have the bolus coming down, and instead of coming down this back tract, we've got bolus that's going to head straight into the lungs. So that is what aspiration looks like. Yep, and there it is again. So it started up here at pooled, and it came down this front tract. So this bolus is unfortunately for this individual heading right into the lungs. Also, back tract is heading into the stomach. Okay, so aspiration on a modified barium swallow study. Time for our second knowledge check. Which of the following structures is not involved in the swallowing process? Nose, lungs, mouth, throat. Answer is nose. So we take in air through our nose, but the nose is not actually involved in the swallowing process. True or false? The swallow is started in the oral phase. False. Remember, the swallow is actually initiated in the pharyngeal phase of the swallowing. If you think about the oral phase as the preparatory phase, all of the things that we do to get ready to swallow happen in the oral phase, but the actual initiation of the swallow is in the throat or the pharyngeal phase of the swallowing. Which of the following are signs of aspiration? Nasal regurgitation, no visible or auditory indication of trouble swallowing at all, unexplained weight loss, choking, coughing, and or watery eyes, Or is it the case that all of the above are potential signs of aspiration? Answer is all of the above are potential signs of aspiration. Remembering and recalling that it just takes one sign to give us a heightened sense of alertness that the individual may be having trouble swallowing, though it's possible that there could be a combination or a myriad of signs for us to recognize. Okay, so let's talk about some risk areas related to choking and dysphagia. What we're going to delve into now, each separately, are reasons that individuals with intellectual disabilities often experience dysphagia more than other people. So we'll talk about some medical reasons, some physical reasons, some behavioral reasons, some environmental reasons, as well as some cognitive reasons. So let's be aware that although this list is not exhaustive, it's a list of very common diagnoses that may change someone's eating abilities and ability to consume food by mouth safely. And so some of those diagnoses include IDD, include stroke, CP or cerebral palsy, include GERD, Parkinson's disease, dementia, seizure disorder, a history of choking in and of itself, as well as just a history of respiratory problems and or aspiration pneumonia. And it makes sense that this is a highlighted list of prior medical history diagnoses that are related to potential swallowing trouble because of the fundamental underpinnings associated with each of these diagnoses. So, physical challenges related to swallowing difficulty. Let's start in the mouth. While teeth are not necessarily required to consume food, it definitely makes the process of chewing much easier. And so when our teeth are missing or in ill repair or are misaligned, then individuals have to develop for themselves compensatory mechanisms for chewing that make that process of creating a bolus a little less effective, a little less efficient than somebody who doesn't otherwise have challenges in the mouth. So examples of things that could be related to dentition that could cause challenges are loose teeth, rotten teeth, history of extractions or otherwise missing teeth, cavities or tooth sensitivities, dentures that don't fit well, palate changes or abnormalities, as well as abnormalities of the tongue. So we look often at individuals who, this is a very visible thing, right? So individuals who have challenges in the mouth often present with an oral phase of swallowing that looks very different from a more typical swallowing pattern. And as I indicated, these individuals know themselves well and have learned what they need to do to be successful with the swallowing process and often develop for themselves compensatory strategies for swallowing, but those compensatory strategies in and of themselves cause challenges and oftentimes more unsafe swallowing patterns than the individual would otherwise have. It is super important for us working with individuals with IDD to recognize that, especially at the level of the teeth, the swallowing pattern, if there are teeth challenges, often results in what we call a tongue thrust pattern of swallowing, where the individual uses the teeth in a different way or use the tongue in a different way than a typical swallower would do. So in the typical swallow, the tongue is strong enough and is proportionate enough to the palate and to the cheeks that will use the tongue. If you imagine the front of my fingers being the front of the tongue, the back of my hand being the back of the tongue, to propel the bolus backwards in the mouth down to the throat. But if my tongue is weak, if I have trouble coordinating my tongue in my mouth, if my tongue lacks sufficient range of motion, or my teeth are in ill repair, oftentimes we'll see individuals swallow like that. And what that shows us is the individual has recognized their limitations, but still knows that the food needs to be moved from the front of the mouth to the back of the mouth. And so instead of the tongue doing the work to get the food to the back of the mouth, what they're doing is raking that bolus with their teeth to the back of the mouth. So chewing concerns, like we talked about, because of the challenges with the teeth, sometimes these individuals don't chew food completely. Sometimes the chewing is absent, and so instead of it being incomplete and kind of a half chew, they skip the chewing process altogether and attempt to swallow food without chewing, which presents challenges in and of itself. We may have slow eaters. If your teeth are sensitive, if you have cavities, if they're loose or uncomfortable, then the process of putting food between your teeth becomes less than desirable. And so then we don't want to do that quickly. We compensate for the discomfort by chewing slow. We already talked about tongue thrust. We talked about difficulty coordinating the chewing and the swallowing, potentially initiating that swallow pattern. And then other physical challenges, other things we chatted about earlier, like pocketing food, holding that food underneath the tongue or in the cheeks, sometimes in the roof of the mouth. Some physical reasons for swallowing concerns include a slow swallow. So individual, as we saw in that modified barium swallow, may require multiple swallows to get the food fully, completely out of the mouth and down to the throat, not chewing properly or enough between bites. So sometimes instead of a slow swallow, we have folks that eat too quickly. We may lose food from the mouth or the nose after putting it in and attempting to initiate that swallow. We may lose saliva from the front of the mouth. There may be coughing or throat clearing, even something as seemingly benign as throat clear could indicate a red flag for potential dysphagia. And again, the timing is important. It could be immediate. It could be minutes or hours after that swallowing has occurred. Again, our individuals are very smart, so we may start to see them refuse to eat. We may see them try to drink without chewing the food, thereby pushing that bolus down before it's ready to go. And in other cases, we may see individuals compensate for their swallowing challenges by attempting to make themselves vomit so that they don't have to swallow. So as it relates to physical reasons for swallowing challenges, we want to make sure that we're setting our individual up with as best of a possibility for safe swallowing as possible. And I believe there are a couple of slides later, but while we're here, we can talk about it now and then review it later. We encourage, to the best of the individual's physical capability, them to be seated for a meal in what we call 90-90-90. That means a 90-degree angle at the hips, a 90-degree angle at the knees, and a 90-degree angle at the ankles, so that the individual is as upright as possible for the meal, allowing gravity to help propel that bolus into the stomach once the swallow renders itself not volitional anymore. So related to posture and that 90-90-90, we want to be aware of individuals who may need more encouragement to be seated or positioned at a 90-90-90 during the feeding process. And recognizing too that there are some individuals, as a function of their medical diagnoses, aren't able to achieve 90-90-90. So we want to put them in position before a meal, repositioning them as often as necessary during the meal to prevent posturing that would be misaligned with the goal of upright and 90-90-90, because we know that the positioning of an individual is directly related to the ease of their swallowing, among many other factors. So we're looking for individuals with a stooped posture. Are we able to sit them upright so that their spine and their back can be as upright as possible? And some of our individuals, specifically our individuals with cerebral palsy, often have a hard time keeping their head up, or maybe they lean to one side. And so what we want to try to do is position them as close to midline as possible, but with their chin down, so that we can get that spine aligned towards midline as much as possible. Why? We know, based upon science and other research, that it's very hard to swallow when your head is down. Though I would rather have an individual with a chin down during a swallow than an individual with a chin up during swallow. Because if we have an individual who has swallowing challenge and they need some positioning recommendations along with potential modified diet recommendations for liquid and or solid, oftentimes we'll tell an individual to drop their chin to their chest. It's called a chin tuck. And that allows the anatomy of the body to protect that pathway to the lungs as much as possible, such that if the epiglottis doesn't flap over, protecting that tract on its own, or needs a little bit of external support in doing so, then dropping that chin to the chest and then initiating the swallow will provide a little bit of extra safety for that individual. In comparison, if an individual is postured with their head back because that's their habitual posture, or because that's how we sat them up, but now their head is back, we want to do our best to provide supports either on both sides of the head, perhaps at the base of the head, so that the chin can be as neutral as possible, so that the swallowing has its best opportunity for the bolus to go to the stomach rather than to the lungs. In an elevated chin position, what we do actually is give a direct line or direct track to the lungs with the chin up rather than the chin in neutral. Right. So other physical reasons for swallowing challenges include the individual's inability to feed themselves. So whether that's through weakness or neurological difference, if there's limited or no control over the upper extremities, then we may have to assist the individual to feed, or we may be feeding them in total. And in the second phase of this course, the in-person section, we'll talk more thoroughly about the experience of being fed, making sure that, again, we're positioning the individual, allowing them ample and appropriate time to swallow between the bites that we're administering to them, talk about appropriate bite size, and the dynamic involved in feeding an individual. We want to take account of the individual's ability to control their body if in fact they have a condition that they experience spasms or tremors, much like Parkinson's disease, so that impacts their ability to feed. But if there are tremors or spasms in the upper or lower extremities, depending upon the progression of the disease process, oftentimes those tremors and spasms can then impact the swallowing process as well by virtue of the musculature associated with the mouth and with the throat as well. So in those instances, we'll offer use of some adaptive equipment that we'll talk about later in this phase one of the training. And if that adaptive equipment is part of the feeding and diet modification and orders, we want to make sure that we're using that equipment every single meal, every single opportunity. So as we indicated, but just so that you have here, recognizing coordination challenges, muscular weakness, being sensitive to the time that it takes an individual. One of the worst things that we can do for an individual with dysphagia is rush them through their meal, because there may very well be a muscular reason, a neurological reason, or an aversion reason that they're taking more time than we would expect to complete that process of swallowing. Last but not least, we need to be aware of the side effects of the medications that our individuals are on, and make sure that they are awake and alert enough to consume food orally so that they are best primed for success during that meal. Other physical reasons related to potential swallowing challenges include sensory issues. Eyesight, though your eyes are not directly related to the process of swallowing, we want to make sure that the individual who is consuming food can see what it is that they're eating and make sure that everything that's on the plate is something that they can appreciate and that they're not just attending to a certain half of what's on their plate, so that we're looking out for a potential visual neglect, making sure that they can see what it is that they're eating, how they're going to get it from the plate or the bowl to their mouth, and making sure that there isn't an overt sensitivity to taste or texture. The individuals that we're working with may actually have a challenge whereby they don't prefer food. And so if they don't prefer it, then they want to swallow it really quickly so that they don't have to experience that. And that is just as potentially challenging for their safety as some of the other physical challenges that they may not actually be in control of. Okay, so physical warning signs to make sure that we alert ourselves to. If food or liquid remains in the mouth, but specifically on the roof of the mouth or coating the tongue after the swallow, we want to be aware of that, because what that shows us is that their initial swallowing attempts were less than effective. And if we can't clear the mouth between each and every bite, we run the risk of the bolus getting too big and then getting lodged in the throat. As we've chatted about, food spilling out of the mouth before the person is able to initiate a swallow, or even after the swallow, if the food or the liquid comes out of the nose or the mouth. And then coming full circle, if the individual is trying to swallow too big of a bolus, or we see repeated attempts at swallowing the same bite of food, just like we saw in that modified barium swallow study, the individual just trying to initiate the swallow, and maybe only a little bit is going down at a time, or despite their best efforts to swallow, nothing is going down. Other physical warning signs include that raking motion, right? So the tongue is pushing forward and the teeth are raking the food back. The challenge with that tongue thrust pattern of swallowing is that oftentimes individuals that are using that compensatory mechanism get food to the back of the mouth before they're actually ready physiologically to initiate that swallow. And so then food's going down, or liquid, to the level of the throat before they're prepared for it. And then their muscles can't catch up with the food and it goes down the wrong way. If that's the case, or even if it's not, then we may see coughing, gagging, throat clearing. We may hear that gurgly voice. If there's, again, some excessive drooling associated with the swallow, that may be an indication of swallowing challenges as well. Individual who has weight loss because they're avoidant of certain liquids or food textures, as well as food feeling like it's getting stuck at a certain level. Most often individuals will indicate an area of the throat, though it could be getting stuck at the level of the mouth as well. Okay, switching gears a little bit. Some behavioral reasons why individuals may experience swallowing challenge or inability. Stuffing food in their mouth, as we've already chatted about, is problematic because if there aren't sufficient swallows to keep up with the amount of food in the mouth, then it becomes a situation where there's too much food in the mouth and trying to swallow will be ineffective. Stealing food, hoarding food, eating food secretly is a challenge because usually those are situations where an individual is consuming food quickly so that they don't get caught. And as we've already chatted about, consuming food too quickly certainly is a potential risk for not being ready to swallow, and then the swallow not being successful, food or liquid going down the wrong way. Eating things that are not food, otherwise referred to as pica, is for obvious reasons a great concern. Eating while running, eating while talking, or eating too fast are all definitely behavioral observations that directly relate to potential swallowing concern or challenge. Again, not an exhaustive list, but last but not least, for highlight purposes, if an individual is ruminating, so bringing food from the mouth, or oftentimes more often from the stomach back up into the mouth, chewing on it and swallowing it back down is definitely cause for concern, not only from a dysphagia perspective, but also from a GI perspective. Because if an individual is able to bring food from the stomach back up to the mouth, then not only are they bringing the bolus back up, but now we're churning stomach acid and oftentimes burning the lining of the esophagus in the process of that rumination. And so now we're looking at not only a diagnosis and management of dysphagia, but we're also looking at potentially modifying the diet and looking at medical management of a gastroesophageal reflux disease as well. All right, yet another reason for potential swallowing concerns, we talk about environmental situations that could relate to swallowing challenge. So if the food or the liquid are not prepared according to the diet order, that is a huge red flag. And one of the best ways that you can empower yourself as a trainer and then train the trainers in your agency is making sure that they are more than familiar, know the information about diet modifications for solids and liquids backwards, forwards, and in your sleep, so that if you're working with an individual that has a modified diet and you come upon them during a meal, you can look and instantaneously recognize what's on their plate and know if that aligns with the diet orders that are specific to that individual. And if they're not, that you take action immediately. Storage. If the individual has access to food that's not safe for them, then that becomes a challenge as well. Or even if they are aware of storage areas and then are able to gain access to those storage areas, and that becomes problematic. We get into situations like we just discussed, whereby potentially they're hoarding food, they're secretively eating, and want to make sure that we prevent those for their best safety. Pica, making sure that if the individual has a predisposition for mouthing or otherwise trying to consume items that are not food, that we make sure that those items are not in their possibility of access, so that we keep them safe. The items on the right side of your screen are especially important and want to give consideration to how impactful the changes in location, distraction level, and seating could be for an individual, recognizing that consuming food is one of the most social things we do as humans, and making sure that we have the recognition that what works for us and is best for us may not be the case for the individuals with IDD that we're working with. So while it is convenient oftentimes and pleasurable oftentimes to eat at a restaurant, that may be too distracting for the individuals that we're working with. Many of us, probably before you joined this course, if you weren't otherwise in the world of choking and dysphagia, may not have taken the time to think about all of the distractions that are present and all of the environmental differences that are present in a restaurant, the amount of noise, the amount of people moving around, and take for granted the ease with which you swallow. Individuals who have dysphagia often have to very much, in a hyper-aware sense, think about what they're doing, when they're doing it, while they're chewing and swallowing food. And if they need that level of focus and concentration, the difference in lighting, the difference in noise, even the difference in where you're seated in a restaurant could be incredibly beneficial or incredibly detrimental to the success that they have during eating. So thinking about location, thinking about crowds and noise and lighting, also thinking about seating too, making sure that the individual is postured as optimally as possible, given their particular constraints muscularly and structurally, but also if there are no muscular or structural constraints, thinking about what we know about that person as an eater, making sure that we limit access to unsafe food, limit access to others' food if they're known to take food from others, especially if they're on a modified diet. As we indicated, some adaptive utensils. So what you have here on the top left is called a nosy cup. And the idea behind a nosy cup is to allow individuals to tip the cup up and get the residual liquid from the cup without tipping their head back. So straws can be an incredible challenge for individuals who are on modified diets because of a dysphagia diagnosis. Why? Because when we put a straw in our mouth, oftentimes we don't load the straw just at the level of the lips. Oftentimes we put the end of the straw towards the middle of our tongue, sometimes towards the back of the mouth. And the relevance of that is that's where the liquid's going to start, and that's where the individual starts the swallowing process. And so if they have coordination challenges in the oral phase, in the mouth, or they have challenges with their strength, and it takes them more time to move things back. What we've done with a straw is diminish the time that they have to prepare that bolus in the mouth, and then they're initiating swallow before they're ready, and likely will penetrate or aspirate that bolus. So if we take straws away, then we're looking at drinking from an open cup. And if the individual is so inclined to get everything possible out of that cup, we all know that we're equally guilty of taking a cup and tipping it back and finishing what's in that cup. The challenge with that, though, is we talked about we want to keep that chin in neutral so that we can mitigate the challenges with giving a direct access line from the mouth to the lungs. So the nosy cup allows that cutout to accommodate for the nose and allows the cup to tip farther because the rim is different on one side versus the other. The middle picture is a plate with an elevated side to allow individuals with motoric challenges in the upper extremities to essentially scrape the food to the side with the lip and then pull the food up. On the top right and the bottom left, you have two different types of cups, one with the straw. Not every individual with dysphagia is limited on straws. Some are, some aren't. But those are two examples of what we call metered cups. One has like a sippy lid, one has a straw, but the idea is that no matter how much the cup is tipped, the individual who's responsible for assisting with the meal puts the cup on a certain amount of liquid, and no matter how much or how long that cup is tipped, the predefined amount of liquid that amount will only ever come out. Then the cup has to be reset, and then the individual can take another sip, and then again only the predefined amount of liquid will come out. It slows the consumption process of liquid specifically. A lot of our individuals with dysphagia have a challenge with what we call consecutive swallows. So just I tip and I swallow, swallow, swallow because my system can keep up with rapid successive swallows, but most individuals with a dysphagia diagnosis cannot. So this is a nice way to prevent the individual from putting too much liquid in their mouth at one time and then being unable to keep up with that amount of liquid. Bottom right, you have some adaptive utensils that are bent in a certain way to take account for potential range of motion challenges in the wrist, in the forearms, in the upper arms in total, as well as the handles being thicker to take into account some fine motor challenges as well. Again, not every individual with a dysphagia diagnosis will require a adaptive utensil. Some will, some won't. Not every individual will require every possible adaptive utensil. It's up to the speech pathologist, oftentimes the occupational therapist, to look at what the challenge is as it relates to utensils, look at what the underlying reason for that is with regard to structure and function of the muscles, and then to put in play recommendations for those adaptations. Last but not least, in the bottom center, you have an alternative augmentative communication device, one of many on the market at this point in the tech-savvy world, but it allows the individual, in this instance, a speech-generating device, or otherwise called a high-tech AAC device, allows the individual to press a button and the device then to speak out what that button represents. So depending upon the individual's language understanding capabilities, and if language expression is hard, if understanding is good though, and they have enough gross motor control and fine motor control to access buttons, they can then, by virtue of this high-tech speech generating device, and tell their communication partners, tell their feeding partners, no, I don't like that. No, I don't want any more. I want more time. I want more food, whatever it is that's programmed on that alternative augmentative communication device. All right, some cognitive reasons for dysphagia or swallowing challenges. Forgetfulness. Sometimes our individual, and this relates back to what are some medical diagnoses, Parkinson's disease, dementia, sometimes IDD. Individuals don't have a functioning pituitary gland that allows them to feel satiated or feel hunger. And so if they're not reminded to eat, they don't eat. And that obviously then translates into unexplained weight loss. Individuals with a visual neglect. So all of this is kind of hopefully coming full circle for you, all the things that we've been talking about. If the food is not right there in front of them, and in some cases, even when it is right there in front of them, if they then don't have the verbal cue or the tactile reminder, hey, don't forget to take a bite, they may forget to eat. If the medication that they're on makes them more sleepy and sedated than not, or if they're so sleepy that it's not safe for them to eat, that can negatively impact their ability to meet their nutritional needs as well. Again, pica, individual not able to tell the difference between food items and non-food items. And so at times they eat food, and sometimes they attempt to eat things that are not food. Refusal, like we chatted about, inability to control the bolus or the saliva in their mouth. And then as we chatted about in the setting of the adaptive equipment, inability or challenge with the skills required to perform the tasks associated with eating. All right, so I like to say knowing is half the battle because I grew up in the era of G.I. Joe. So what do you do if you see it and you know it? What are the next steps? Everybody on the team is responsible for observing these challenges, these behaviors, and then in turn communicating those challenges and potential behaviors and abilities to the next person in charge at your facility. When do you do that? To whom do you do that? That's your agency's reporting policy. So the person that's training you will give you that information, but MDH and DDA have provided this choking and dysphagia risk monitoring flow sheet so that will hopefully guide your informed observations about next steps when you're working with an individual who you've identified now based upon this training or other experience and knowledge as having a risk or an identifiable challenge associated with swallowing and the process thereof, so that you know who to tell and when. The when is always as immediately as possible. The who depends upon the monitoring flow sheet that you have here. Okay, at this point, let's talk about altered consistency diets and thickened liquids. And so when we talk about orders for modified diets, we really parse out into two different lines of thinking. Food items, those solids, in comparison to liquid items. And so first we'll talk about solids. So if an individual is ordered a regular diet, there is no extra preparation that's required for a regular diet. Individual may still need adaptive equipment associated with consuming a regular diet. So maybe their liquid is in a nosy cup, maybe it's in a metered cup, maybe they're using utensils that have those larger barrels for being held. But the food itself requires no extra preparation. It is the same preparation as anybody else that would eat. One level down from a regular diet, so one modification, is what we call a bite-size diet. And that's where we break down or cut food into 1-inch pieces. Best way to conceptualize that is the size of a wheat thin, the size of a Cheez-It, those are 1x1 squares, or a US quarter. If you're ever uncertain, pull out a ruler, measure for accuracy. All right, so 2 levels down from a regular diet, 1 level down from that bite size is what we call a chopped diet. And that's where we're gonna chop our meats into 1/2-inch size. Other soft foods are also cut into a 1/2-inch size. So recognizing this is an additional level of modification because our bite-sized diet was 1-inch pieces. Now in a chopped diet, we're talking about 1/2-inch pieces. Examples of foods that align with a chopped diet are cooked vegetables cut into 1/2-inch size, cake that's 1/2-inch sized, pasta and soft cheeses. Another way to conceptualize it, if you think about fruit cocktail, those fruit cups, those fruits are already pre-packaged and cut into 1/2-inch size pieces. The grapes are a different story. We'll talk about that in a little bit, but the actual peaches and melons and pears are cut into 1/2-inch size. When we talk about a chopped diet, as it how does a sandwich fit into the metric of a chopped diet? We'll need to cut that sandwich into 8 pieces or more, such that each piece of the sandwich is no larger than a 1/2-inch size. And we want to make sure that we use breads and fillings that are soft. So tuna salad is a great option. Egg salad is a great option. Seafood salad is a great option. Shaved lunch meats are what we're going for, not medium cut, not thick cut. Sloppy Joe meat, so real ground turkey, ground beef are great examples of what would fit into a chopped diet. And so if you think back to the first picture that we showed where there was a regular diet, there was a whole piece of Salisbury steak, and those green beans were probably an inch or more in length. Now we've chopped those vegetables that are soft and cooked into 1/2-inch pieces, and the bites of Salisbury steak are now 1/2-inch sized as well. All right, further level of modification, so now we're 3 levels away from a regular diet, is what we call a ground diet, making sure that the foods that the solid food that we give the individual are the size of a grain of rice, and that the texture is moist and soft, nothing hard. Often to successfully get solid food to the level of ground, we're going to need to prepare that food with a blender or a food processor. We need to be mindful that individuals who are consuming a ground diet, as we prepare their food, we're likely going to need to add some condiment or some liquid to the protein to achieve that requisite texture and size. So great examples to think about for ground diet. We chatted about the 1-inch size versus 1/2-inch size. Now we're at size of a grain of rice. We want to talk about how small we would think about taco meat being, or a single grain of rice. All right, so thinking back to our original plate of food, now we see that those green beans are to the size of a grain of rice, as well as the meat is now cut very, very finely, likely not cut by hand, probably put into a food processor or a blender. All right, last level of modification is a pureed diet. So if an individual is consuming solids that are pureed, we're looking for a consistency that is smooth. No lumps, no bumps. We want it to be very much pudding-like. The pureed food should be smooth and thick enough to mound on a plate or mound on a spoon. in order to get our protein again to the consistency of puree, we're likely to have to add some moisture by virtue of condiments, gravy, water, to get the food to be a puree that has no lumps and bumps. Examples of pureed foods include mashed potatoes, not your lumpy mashed potatoes, it's got to be smooth, pudding, applesauce, and yogurt, making sure that the yogurt has no fruit pieces in it. Again, smooth, no lumps and bumps. Same plate of food, now prepared, pureed. So mashed potatoes, no lumps and bumps, extra gravy to assist the swallower. Our Salisbury steak is now one smooth consistency. No more grains of rice, no lumps and bumps, just smooth, extra gravy to support. And now those green beans are one smooth consistency as well. All right, so in thinking about a pureed diet, we want to make sure that we take the food and prepare it as we typically would for a regular diet, as well as season it and then puree it. So taking that original food and adding that moisture as need be to make sure that we get the right consistency. It shouldn't be too runny, but it shouldn't be so thick that the individual will risk it getting stuck, much like a peanut butter sandwich would, in their throat. It is incredibly important for the dignity of the individual that's eating a pureed diet, as well as the desire of the person to have the buy-in to consume a pureed diet, that we puree all foods separately. We want to, just like that photo showed you, I'll go back. This is not the case that we put the green beans with the Salisbury steak, with the mashed potatoes in the blender all at once and serve them what would ultimately become a not lovely presentation of mixed colors and say, here's all of your food, consume it together. But rather, we pureed the Salisbury steak and presented it as a separate pile from the mashed potatoes, separate from those green beans. Again, recognizing that we may need to add additional moisture to get to the necessary texture. Again, for the dignity, again, for the buy-in, we want to make sure that we are providing at minimum a neutral presentation to the individual when we present the food to them, whether it's by tray and they consume it, or if we're feeding them, so that they feel as though their meal can be just as enjoyable as the meal that we would otherwise be consuming. If you appear apologetic, if you make negative comments, that sets the tone for them to potentially avoid the desire to consume the food, and then that becomes a nutritional risk for them. All right, G&J tube will refer you back to your case manager, your registered nurse on education training, making sure that you have competency, that there's a skills checklist that you're aware of and have demonstrated competency with, in order to make sure that the individual who can not eat by mouth, otherwise is ordered NPO, to make sure that they get their nutrition directly to their stomach. Separate situation is patient and setting dependent, but there are some individuals who have orders for NPO. They cannot consume anything by mouth. They receive their nutrition through a G tube or a J tube, but have been cleared for pleasure feeding. And you'll have to consult again with your nurse case manager, your registered nurse, to find out what those pleasure feeds look like. For some individuals, pleasure feeding is simply water by mouth. For some individuals, it's puree. For other individuals, it looks a variety of different ways, and the determination of pleasure feeding usually involves the family. It usually involves quality of life determinations for and with the patient, as well as what is safe for that patient, given that their primary nutritional needs cannot be met eating by mouth. Okay. Just like we said, make sure that you've completed your MTTP training if you're working with somebody who's receiving nutrition by a gastronomy tube. And just as important as posture and positioning is for an individual eating by mouth, we want to make sure that the individual who's receiving tube feeding is in an upright position while seated, either in their chair or their bed, with the head of the bed elevated to at least 30 degrees, if not 45 degrees or more, to prevent regurgitation and or aspiration of the regurgitated feed. Once the individual is placed appropriately for the feeding, then we want to make sure that they remain in that upright position for an hour after the feeding. Again, to make sure that we allow gravity to do its job, we allow the individual's internal system to process the feeding that they've received and not risk regurgitation or aspiration of that tube feeding. Okay, so that is solid foods. Let's talk about liquids and thickening liquids. So we want to make sure that you know and understand the definitions of a variety of thickened liquid consistency, and not only understand them from a textbook perspective, but also by eyes, look at them and know that the consistency that is ordered is the one that you're presenting to the individual, or if it's not, how then you would modify based upon what you're seeing. So the goal with thickened liquids is to decrease the risk of or the occurrence of penetration or aspiration by having better bolus formation. So thin liquids require no extra preparation, much like a regular diet. In the world of liquids, thin liquids are liquids that you can consume in their most pure form: water, tea, coffee, thin juices, sodas, smoothies, ice cream, so on and so forth. Nothing extra is required. We want to be mindful that all liquids aren't created the same from a viscosity perspective, such that if you think about how thick coffee or iced tea is, if you compare that to soda, soda's a little bit thicker, plus the effect of carbonation sometimes has an impact on the success of an individual swallowing it. But compare those as well to, say, a V8 juice. Inherently, that V8 juice is just a little bit thicker than that water is. So we want to recognize that the amount of thickener is variable, and what a thin liquid is a little bit different according to what the actual liquid itself is. Okay, so one level of modification for liquids is what we refer to as nectar thick. The marker, or the identifier visually for a nectar thick liquid is that when a liquid is thickened to a nectar consistency, the individual can still consume the liquid through a straw if that's their preference and it's safe to do so. And if we are stirring a nectar thick liquid, that liquid will just very easily glide off of a spoon. Conceptually, we want to think about how thick pancake syrup is, how thick an eggnog or a V8 juice might be. They are intrinsically, inherently a little bit thicker than a water, a coffee, an iced tea, and definitely exemplify the consistency of a nectar thick. Very, very, very important to recognize that if an individual is ordered for a nectar thick diet, that we do not allow that individual to consume frozen drinks like milkshakes and smoothies. Why? While those beverages begin thicker, admittedly so, a milkshake and a smoothie, what happens is when that very cold, thicker liquid enters your 98-degree mouth, it very quickly turns into a thin liquid. And so if an individual cannot safely consume thin liquids, if we allow them to have something that is outside of the mouth thick, but then immediately turns into a thin liquid, we are unfortunately not in compliance with the diet modification orders. 2 levels of liquid consistency away from thin liquids is honey thick liquids. So whereas your nectar thick liquids are able to be consumed through a straw because they are thin enough to do so, honey thick liquids should not be able to flow through a straw. They should be able to slowly flow off of a spoon. So again, your nectar thick freely glide off. Your honey thick flows off of a spoon, but definitely in a slower speed. You want to think about conceptually the viscosity of a molasses or honey, and that will correlate hopefully pretty easily in your mind with what a honey thick liquid should be. All right. 3 levels of modification for liquid is what we refer to as pudding thick liquids. Pudding thick liquids have to be fed with a spoon. So you are, in this situation, eating your liquids because they need to be so thick. Examples of pudding thick liquids are pudding or yogurt. So again, they'll mound on a spoon, much like that puree consistency. We want to make sure that they're smooth as well, and we're avoiding foods of mixed consistency. What's a mixed consistency food? Foods that in and of themselves have residual liquid in the food. So you want to think about fruit as a great example. So watermelon is a food, but then has all of that extra juice associated with it. Same thing with a fruit cup. That fruit itself is embedded in the liquid, and if we're not careful to drain the liquid from the fruit before we consume it, then very quickly we're eating and drinking at the same time, which becomes a challenge for an individual who requires thickened liquids. Additionally, soups and cereals are also mixed consistency foods. So we're talking about mixing potentially a solid with a liquid and putting them in the mouth at the same time. And the individual with a swallowing challenge is oftentimes going to have trouble separating out the liquid and the solid, sending the liquid down safely and successfully first, and then chewing the swallow afterwards. So for an individual who is ordered on a pudding thick liquid diet, we don't provide them with opportunities for mixed consistencies. Okay, so key warnings to adhere to. We're not going to give ice cream, sherbet, smoothies, and the like to individuals who require thickened liquids because it melts to a thin liquid like we chatted about. We want to make sure that we follow the directions on the thickening agent packaging to a T to achieve that consistency as ordered. Different types of thickeners require different amounts of time and different levels of mixture, and they also will hold their consistency in different timelines. So there are gel thickeners and there are powdered thickeners. Both work quite successfully, but with a gel thickener, oftentimes it takes a little bit longer to get to the consistency visually and by test and trial than a powder would, but it holds its consistency a little bit longer than a powder will. So conversely, oftentimes you'll get your thickened liquid to its desired consistency a little bit more rapidly by using a powdered thickener, but that beverage will hold its consistency less long. Meaning if the individual is altering, taking a bite, then taking a drink, taking a bite, then taking a drink over time, and oftentimes rather quickly, the nectar thick liquid that you made, by the time the individual is halfway or done their meal, has now become a honey thick liquid because the longer it sits, the thicker it gets. It's never a bad thing to give an individual a liquid more thick than they need, but it's absolutely detrimental to give an individual a liquid that's less thick than they need. We should be aware though that oftentimes the individuals we're working with are a mixed crowd when it comes to acceptance of thickened liquids. So if you're already having to persuade an individual that nectar thick liquids is what is right and best and safe for them, and that it will very little, if at all, change the taste and flavor of the beverage that they're going to consume, oftentimes you get a little bit of pushback. And so then if you let it sit even longer and now they're eating their liquid, they may be less than willing to consume that thickened liquid. So make sure that you're constantly not only reevaluating the position of the individual that you're feeding or helping consume food, but you're also constantly reevaluating the viscosity of the liquid that you've been required to thicken as well. And then if an individual is taking medications with liquids, it does not mean that that liquid then also doesn't have to be thickened. Any liquid at any time must always be thickened if that is the order. A note on the International Dysphagia Diet Standardization Initiative, IDDSI, is a new naming system within the last couple of years for altered consistency diets and liquids. Important to note that not all facilities use IDDSI, so you may find that there are places that you're working in that aren't using regular or soft and bite-sized, minced and moist, but rather they're using chopped or they're using other terminology. By and large, most of those terms mean the same as previous terminology that's not IDDSI. Interestingly enough, though, there are some terminology that are being used in some facilities that do not have a direct IDDSI correlate. And so in those instances, what we are recommending that you do is speak up and make sure that if you don't understand the size or the size of the solid or the viscosity of the liquid that the client that you're working with is ordered to consume, that you ask. Please don't make an assumption that it's all the same or that less is better or that more is better. Educate yourself, refer back to this training and make sure that you understand what you see, you can identify it, and it is in fact in line with the diet that's been prescribed by the physician. All right, knowledge check. That was a lot of information. Want to make sure that this is information that's going to stick with you and that you know it forwards and backwards. True or false? Thin liquids require an additional level of preparation prior to allowing the participant to consume them. False. Thin liquids require no additional preparation. True or false? Honey thick liquids should flow freely off of a spoon, but should not be able to be consumed through a straw. True. Remember, honey thick liquids can come off of that spoon. They should not come off as quickly as a nectar, but they should still come off, but absolutely should not be able to be sucked up through a straw. True or false? An individual who is ordered a puree diet and nectar thick liquids should be permitted to safely consume a milkshake. False. Remember, while that milkshake is thick now in the exterior environment of the mouth, as soon as it gets in that mouth, it's going to melt and turn into a thin liquid. Remember, never a detrimental thing to over thicken a liquid, absolutely detrimental to under thicken a liquid. So if we start with something that's thicker and it turns thin, that is ill-advised for the safety of that patient. All right, so let's order these solid food modifications from least restricted to most. So the least restricted to the most. Want to make sure that you know that the least restrictive food modification is a regular diet. No additional food preparation is required. Then you have a bite-sized diet, 1-inch squares. Then you have the chopped diet, 1/2-inch squares. Then you have ground. Then you have puree. Okay, so let's chat about some safer eating strategies. Lots of different ways that we can think about the safety of an individual while we're helping them or feeding them. The first of which is a physical strategy. So as we had indicated earlier, we want to make sure that positioning is optimal for that individual, achieving that 90-90-90 Angle at the hips, at the knees, and at the ankles. Best way to achieve that is making sure that the individual's hips are as far back on their seating surface as possible. Their feet are on a solid surface. Repositioning as needed throughout the meal may require multiple repositionings at the level of the trunk, at the level of the hips, at the knees, oftentimes at the head, at the neck. We can provide bolsters and wedges, pillows, anything and everything that that individual will need to make sure that they're in the most optimal position for consuming food as possible. And then again, we'll hone in on this during part 2 of this training, but making sure that when we're feeding an individual, we're always feeding them from the front so that they can, as best as they are able, be prepared, be alert for the food that is coming to them. We want to be mindful that we place a reasonably small amount of food on the utensil for each bite. We want to watch the individual and make sure that we give them ample time to not only chew, but to swallow successfully each bite. Offer fluids as needed or directed. Remember, some of our individuals have orders that indicate that they should be taking fluid after every bite of food. Sometimes it's a 2-to-1 ratio, whatever it is. We want to be mindful of the needs of the individual that we're working with and adhere to it every single bite and swallow. Using that adaptive equipment that we've chatted about before, if it's indicated in part of their diet modification plan. Making sure, again, and so importantly, that you know the diet modifications that are ordered for the individual that you're working with, and do a visual inspection of the foods that they're consuming before they begin or before you begin, so that you know for sure that that liquid looks like it's nectar thick if that's what's ordered, that plate of food is 1-inch squares if it's bite size, making sure that it looks like it's a size of a grain of rice if they're on a ground diet. So make sure that what you know is what you see. All right, some behavioral strategies. So seating and supervision during the meal, like we chatted about before, be mindful of the propensities of the individual that you're working with, making sure that we're mindful of the environment, the lighting, the distraction, the access of others' food to a potential person who is known to steal food, to hoard food. Make sure that you position yourself in a safe way to prevent what we know may happen. If we need to put a behavior plan in place, we should do that. If we need to put a diet plan in place, we should do that. Above and beyond anything, the most overriding important principle is pay close attention to the individual that's eating, making sure that they have every possible modification and strategy that aligns with what their needs are so that they can be safe and successful. So important. If you have an individual who has stolen food, we do not want to attempt to then retake that food from that individual. Why? They may take that stolen food and stuff it in their mouth. They may attempt to swallow the food too quickly. They may attempt to swallow too much food at one time. And where we had a situation that we could otherwise de-escalate and diffuse in a safe way by taking care of it in another time and place, though immediately, that in itself is better than being the cause of the individual having a moment of swallowing challenge or dysphagia or choking. All right, so let's talk about the timing of the meals as it relates to one of many behavioral strategies to assist with clients with dysphagia. We want to talk about the frequency of the meal. Maybe our clients are very slow eaters for a variety of reasons, and they would benefit from smaller, more frequent meals. Maybe we need to make sure that we allot for them to have a longer time to eat. Maybe we need to consider that the individual shouldn't eat in the dining room. They should eat in a smaller group of 2 or 3 individuals. Maybe they need to eat alone or just with you so that food can't be stolen from them because they take longer, or maybe the lighting in their room is less distracting to them than the lighting in the dining room or the cafeteria. And we want to be flexible with when we allow the individual to eat too. We talked a lot about the effect of medication. And so we want to make sure that if the individual is too sleepy to eat, that we then offer them food to eat at a time that they're not sleepy. And in so many of these trainings, I think the timing of the meal is the biggest feedback I get from trainers, which is, hey, these strategies and suggestions all sound great, but they're not practical. We have to make them practical. It is our job. It is incumbent upon us to make sure that we consider all of the aforementioned ideas here: frequency, duration, timing, and time of day, among many other considerations, to make sure that we keep our individuals as safe as possible. And so often it's a tweak of one of these things, maybe two, maybe all of them, but a tweak of the timing can make a world of difference in a positive way for these individuals. And sometimes, along with other modifications, we need to look at cueing or prompting our individuals. And so we can do that in many different ways. Again, some individuals respond better to one type of prompting than another. Some require multiple levels and multiple types of prompting. So maybe that they just need an auditory reminder, a verbal cue. Hey, don't forget to eat. Hey, go ahead and take a bite. Hey, don't forget that you have to take a drink after you finish that bite of food. Hey, let's finish this bite of food before we start taking the next bite of food. Anything that you can say to them is a verbal prompt. Sometimes pictures carry more meaning for individuals. So maybe we'll come up with a social story. Maybe we'll come up with a picture board, and not only just have pictures of their food, but also have pictures of cues related to the same type of verbal prompts. One bite at a time, first food, then drink, whatever it may be, pictorially represented. Sometimes the individual requires a tactile cue or a physical cue. So that's us actually touching them. Maybe we're guiding at the elbow. Maybe we're taking our hand and putting it over their hand to show them where to place their arms, their hands, their fingers to best manipulate food to get it from the plate to the mouth. Maybe we're modeling. We can do a lot of things to make the individual as independent and as safe as possible during the process of eating. More than anything else, give them time. Create a slow routine full of as many prompts as necessary, but not more than as necessary, least restrictive amount, to be able to allow the individual all of the strategies that they need to be a safe, successful, independent eater. All right, so how are we going to know what's going to work? It's trial and error. It's based upon our educated hypotheses. And you can mind hive with your team. You can mind hive with the rehab team. Check with the occupational therapist. Check with the speech language pathologist. Ask them what they've had success with. Ask them what they haven't had success with, so that you're not reinventing the wheel, allowing the patient to try different things until you find out what specifically works for them. To the greatest extent possible, have consistency among the caregivers so that the individual has confidence and expectation that what has occurred before will occur again, so that they feel like they're in a place and in an environment that will allow them all of the modifications necessary to be successful. How do we slow down eating for our individuals that really just enjoy food so much and they eat so quickly, sometimes to their own detriment? Lots of things we can try. Maybe we give them smaller portions of the meal at a time. So maybe they're an individual that requires 2 or 3 or 4 helpings of food, and it's not really that they're having 4 full helpings, but we've quartered the meal, so that we give them just a little bit at a time, so as to slow their pace of consumption. We can give them smaller utensils. We talk about a soup spoon versus a dessert spoon. It's much easier to get to the point where the person takes smaller bites if they can't load as much onto their spoon because the head of the spoon is smaller. We can give them those verbal or visual or gestural prompts to slow down. Sometimes I like to, if the person will allow me, to kind of hold their hand between bites and then gently release, or just allow me to put my hand on top of their hand between bites. That physically slows the process of being able to get food in quickly. To the extent that it's safe, because not all of our individuals are safe to coordinate talking and eating. But if it is, we can engage them in conversation. Hey, before you take your next bite, I have a question for you. What do you think about? Allow them to talk and tell you, then give that verbal cue to return to their next bite. Along with the idea of putting a hand over or holding hands, requiring them to set their utensil down during between bites during that meal to facilitate that process. Again, small little things that will net you a second or two or five, but those 1 to 2 to 5 seconds allows extra time to process that food in the mouth, get it to be safely swallowed. And then checking the spacing at the table as well. We want to also think about constantly reevaluating the diet consistency. Just because your individual is ordered diet modifications, if they then begin to sometime later, days, weeks, months, years, show new, different signs of dysphagia, we want to be on high alert. We go back to our risk assessment flow sheet, alert the people that need to be alerted so that we can potentially reassess for additional changes that might need to be made. We talked about environmental factors. We want to make sure that we modify the lighting as much as possible. Some individuals need a very bright, well-lit space. For some individuals, those fluorescent lights are too bright and they're distracting and hurtful and harmful. And so then we want to allow them to eat in a more dimly lit environment, but an environment that is still lit enough that they can see the food that they're consuming. We talk about sound. Some individuals really need a serene, quiet environment void of any sound in order to concentrate on the food that they're consuming. Some individuals, that's too distracting. Silence is distracting, and so then we provide some background noise, whether it's white noise, whether it's conversation, whether it's music. It's all individually identifiable and effective. We just need to work at trialing and error and figuring out what works for the individual that we're working with. Knowledge check. Pacing strategies are an effective means to slow the rate of food consumption. We know this. Which of the following are useful pacing strategies that can be employed with the individuals with which you work? Engaging the individual in conversation during the meal if it's appropriate and safe to do so. Requiring the participant to put their utensil down on their tray or table. Using verbal, physical, or tactile and or gestural prompts as needed to decrease the rate of food and liquid consumption. Or are all of the above effective means as well as many others? All of the above are effective strategies, as well as others we chatted about, and I'm sure others that you may creatively develop on your own. True or false? It is not necessary and disruptive to the eating process if a caregiver repositions an individual for optimal eating positioning during a meal. False. While it might be marginally disruptive to the individual, it is absolutely necessary that you constantly throughout the eating process reevaluate the positioning of an individual to make sure that they are in optimal positioning for eating. Some reasons individuals with IDD are diagnosed with dysphagia more often than other people include which of the following? Behavioral challenges and differences, physical challenges and differences, cognitive challenges, medical diagnoses, and the challenges that they present, or all of the above. All of the above. All right, so let's talk about some case scenarios and some suggested prevention strategies related to the specific challenges that the following patients present with. So we'll talk about Sue. Sue has a history of eating too quickly and not chewing her food thoroughly. What would you do to keep Sue safe when she eats? So let's talk about some interventions. We can break them down by category. Physically, we can ensure that we prepare Sue's diet as ordered. We can use adaptive equipment as indicated in her plan. We'll make sure that she's seated upright at 90, 90, 90. We'll keep her feet on the floor or some other solid surface and be prepared to assist her if she chokes, always following the directions in the nursing care plan or the person-centered plan. Environmentally, we'll make sure that the environment is as well lit as Sue needs. We'll make sure that the environment is as distraction-free or as calm or as engaging as Sue needs. And we'll make sure that there's appropriate space between all of the people at the table that Sue shares space with. Behaviorally for Sue, we'll follow directions in her behavioral plan. We'll supervise Sue whenever food is present, and we'll make sure that she has plenty of time to eat. We'll encourage swallowing in between bites by using pacing techniques. Ideas for Sue might be wiping her mouth between bites, putting her utensil down on her tray or table between every bite, allowing her to have a drink if it's not contraindicated between her bites of food, and engaging in social conversation with all of the individuals at the table with her. We'll make sure that we give Sue small amounts of food at a time. Maybe she's one that we take her food in total and give it to her quarter portions at a time. We'll reduce the size of the utensil when that's feasible. Maybe we use a smaller plate along with smaller amounts of food so that maybe Sue doesn't recognize that she's getting smaller amounts and feels like we're on her side when we give her seconds and thirds. Maybe in addition to all of this, we offer her food more often, perhaps 6 small meals a day as snacks rather than 3 large meals a day. Let's talk about John. How are we going to support John at mealtime when we know that he has a history of choking on stolen food while running off from the staff? Though he routinely eats his lunch in the cafeteria. All right, so physical interventions for John, just like Sue, we're going to use adaptive equipment as indicated, prepare his diet as ordered, and make sure that he's seated upright in 90, 90, 90. We'll be prepared to assist him if he chokes, and we'll follow the directions in his nursing care plan, PCP, or the dining protocol or the dining plan. Environmentally, same as Sue, we'll make sure that it's as well lit and as environmentally sensitive for him as possible with regard to noise and distraction. We'll space people appropriately at the table. We might want to consider for John fewer people at the table so that he doesn't have the opportunity to steal their food. And we would strongly consider placing John at a table that's near the door so that he doesn't pass other diners when he leaves. Behaviorally, we'll follow the directions in the behavioral plan. If eating at the cafeteria at lunch still is problematic because he's stealing food from other diners, perhaps John will need to eat at different times or places than the others do. We will absolutely make sure that we are with John and actively supervise him at all times when food is present, his or others. We'll make sure that he has plenty to eat. Maybe we'll offer food more often, much like Sue, 6 small meals a day rather than 3 large. We'll encourage those same pacing techniques. And again, placing John at a table that's near a door to minimize the opportunity to pass other diners when he leaves, such that he doesn't have the opportunity or as many opportunities to take food from others. Remember, if John does have success in taking food from others, we will not run after him. Once the food is in his mouth, chasing him is only going to increase the likelihood that he's going to swallow it too quickly and potentially choke. We want to keep him in view, preferably contact a different staff person to monitor and redirect him than you yourself, so that we can minimize his fear or risk of being caught and otherwise keep him safe with the food that he was able to access. Let's talk about what we can do to keep Sid safe. Sid has a history of secretively eating, holding food in his cheeks, and hiding food in his pockets. His diet was already recently changed from regular to bite size. So remember now, we have Sid, who shouldn't be able to bite into any food that he wants. All of his food should be in 1-inch size pieces. What can we do to keep him safe? We'll make sure we educate all staff on his diet change so that they recognize that when Sid is around food or presented with food, that it's 1-inch size pieces or less. We'll give him adaptive equipment as needed. Make sure that he's sitting upright, 90-90-90, with his feet on a solid surface, being prepared to assist him if he chokes, and following the directions in the nursing care plan or the PCP. Environmentally, much like our individuals earlier, we'll make sure that the room is as well lit as he can tolerate, is as calm as he needs, or as engaging as he needs, and provide appropriate space between him and others at the table. We'll maintain the cleanliness of his room so that it will be obvious to us if he has taken food. Behaviorally, we'll be sure to follow the behavior plan and watch Sid like a hawk when he has food near and around him. We'll make sure that he has plenty to eat. We will need to prompt Sid, definitely verbally, but potentially tactily, gesturally, maybe even pictorially, to make sure that he does not place food in his clothing. And we are going to be very selective about the clothing that we allow Sid to wear. We'll engage his family as well, and to the greatest extent possible, don Sid with clothing that doesn't have pockets so that he doesn't have a place to hide that food. We'll encourage swallowing in between bites with the pacing strategies that we chatted about with other individuals, prompting him to swallow as immediately as safest for him, wiping his mouth between bites, putting his utensil down between bites if appropriate, and altering bites and drinks as indicated, if safe to do so. Behaviorally, we'll engage Sid in conversation with others at the table and periodically make sure that he is swallowed. Because often we can't do finger sweeps, we can't be invasive and make sure to ask him to open his mouth after swallowing each time. If we engage Sid in conversation, then we can observe his mouth while he's speaking to make sure indirectly that each bite of food has been swallowed before then he takes his next bite of food. We'll give Sid small amounts of food at a time, using a smaller plate, portion his meals differently, maybe even offer food more often. Let's talk about Bill. So Bill is active and he's aware of his environment. He'll often sprint ahead of people and grab items. Unfortunately, those items that he grabs are not necessarily food, and he puts them in his mouth. In other words, Bill has a pattern of pica. What can we do to prevent Bill from choking on non-food items? So we'll certainly be prepared at all times to assist Bill if he chokes. And if he swallows a non-food item, we'll need to immediately report this to the nurse. Behaviorally, we're going to follow directions in his BIP, and we'll supervise Bill as per PCP nursing care plan and his behavioral plan. Additionally, behaviorally, we'll redirect Bill from placing non-food items in his mouth, attempt to keep something in his hands to occupy him so that he's not inclined to otherwise take non-food items and put them in his mouth. And with something in his hands, the hope is that it will slow his ability to grab other items to put in his mouth. We'll remove or block access to any non-food item that Bill puts in his mouth, and we'll watch for cues from him if he's about to put something in his mouth. We'll kind of learn Bill and be able to act hopefully preemptively rather than responsively, but definitely doing both if necessary. Environmentally, we can absolutely peruse the environment, looking around and being aware of items in the environment that Bill has a propensity for putting in his mouth. Mary. Mary's dependent upon our staff for all of her physical care. She cannot sit upright on her own, has difficulty swallowing, and has thus been diagnosed with dysphagia. She's on a pureed diet and thickened liquids. Because Mary can't feed herself, the staff has to feed Mary. So remembering thickened liquids doesn't yet say to what level we're thickening her liquids, but we know that she cannot consume thin liquids. They have to be thickened in some way with powder or gel. And we know that we have to provide Mary with only pureed items. What can we do to assist her? Positioning will be super important because she's dependent upon us. So we'll make sure that her hips, her knees, and her ankles are at 90-degree angles with the chair and a flat surface at her feet. We'll use mechanical supports as necessary and ordered to support her trunk and maintain proper body alignment before the meal as well as during the meal. We'll reposition her head and neck with approved techniques as indicated and necessary throughout her meal. And we will be sure to prepare her liquids and solids to puree and thickened as ordered. We'll make sure that we sit only in front of Mary and present food at a 90-degree angle so that she can see it coming. She can prepare herself and her body as much as possible. We'll use adaptive equipment if it's indicated. And if her feeding protocol indicates, we'll alternate between food and fluids. We'll always be prepared to assist her if she chokes and follow the directions of the feeding protocol, the PCP, and the nursing care plan. Environmentally, we will make sure that we're not going to, as much as possible, feed her in bed. We'll see if we can make every vested effort to get her out of bed when we feed her. If we do need to feed her in bed, we're going to raise the head of the bed to at least 45-degree angle, but ideally 90-degree angle. We'll make sure, just like with all of our other individuals, that the environment is appropriately lit to her needs, as well as auditorily make sure that environment is free from distraction or has the level of engagement that she needs. Most importantly, equally importantly as positioning, we'll make sure that we allow adequate timing for Mary to eat as well. Behaviorally, we'll follow the behavioral plan. We need to make sure that when Mary is fed, because she is dependent upon our staff to feed her, that staff has been properly trained. We'll supervise Mary whenever food is present, give her plenty of time to eat. We'll make sure that she's upright for at least 30 minutes post her meal and encourage swallowing between bites using those pacing techniques that we previously discussed. That can include, but are not limited to, wiping her mouth between bites, setting utensils down, having a drink between bites if indicated, reducing the size of the utensil, and giving small amounts of food at a time. Knowledge check. Which of the following would not be an appropriate mealtime support for an individual who has a history of sneaking and stealing food and running away from staff when caught doing so? Is it requiring the individual to eat in an environment that is fully visually supervised and highly staffed for meals? Is it chasing after the individual when they're noticed with food that's not theirs or permitted? Seating this individual near a door so that they don't have the opportunity to pass others in the dining space? Or is it offering this particular individual food more often, say 6 meals a day rather than 3 large? Which one is not an appropriate mealtime support? Chasing after that individual is not something that we want to do. It is dangerous and will encourage them to swallow too quickly, potentially causing them to choke. Which of the following would not be an appropriate mealtime support for an individual who has postural challenges, is on a modified diet for liquids and solids, and is dependent upon the staff to feed them? What is not an appropriate mealtime support? Feed the individually as quickly as possible so that you can move on to helping the next person in need. ensuring that any postural supports are appropriately activated and set for the individual, such as foot rests, trunk supports, wedges for body alignment, so on and so forth. Visually inspecting the meal and ensuring that it's prepared according to the doctor's diet modifications orders prior to serving and feeding the individual. Or encouraging multiple swallows per bite and alternating liquids and solids if indicated on the doctor's orders. What's not an appropriate mealtime support? Certainly not effective or helpful if you feed them as quickly as possible. We want to allow ample time for the individual to consume the meal that they've been provided. Okay, so what about people who eat independently? The reality is that anyone can choke regardless of the presence of risk factors. So as such, we need to be aware of the person-centered plan and address mealtime or food issues. We need to encourage proper body positioning, pacing, and modify the environment as necessary. We need to encourage adhering to healthy eating or the diet as prescribed. Monitor for behavioral challenges, concerns, or issues. Provide access to that adaptive equipment every meal as needed. And supervise mealtime actively, very engaged, continuing at all times to monitor for signs and symptoms of choking. Just like all liquids are not created the same, all solids are not created the same. And so we want to be mindful that some foods carry a higher risk of choking than others, some of which include hot dogs that are served whole or especially circularly sliced hot dogs. Those circular slices, if not chewed completely, have the width of conveniently blocking the throat. And so that's a concern. Same thing with grapes. Grapes are just the right shape and size that if not chewed completely, even if chewed incompletely, can block that pharyngeal pathway. Chicken on the bone is definitely a risk, especially for our individuals with pica or individuals with lack of oral sensation, that they can't discern the difference between the meat and the bone. Peanut butter, as well as peanut butter sandwiches on soft bread, as they chew and they coagulate, they get very thick, very quick, turn into a bolus that very much mimics a grape or a circular hot dog and can very easily get lodged in the throat. Thick, chewy bread like bagels, pizza, like white sourdough bread, also, when they mix with your secretions and create a bolus, they also create a consistency of a bolus that is very easily lodged in the pharyngeal pathway. Same thing with melted cheese and marshmallows. Again, not an exhaustive list, but definitely high-risk foods to be mindful of. Additionally, dry crumbly foods like cornbread or rice served without some type of lubricant like butter or jelly, a sauce, a condiment, are definitely high risk. They tend to separate and make creating one bolus a bigger challenge. So then consuming and swallowing it all at once is harder for an individual. Similarly, dry meats like ground beef or steak, drier chicken, a drier pork without sauce or gravy functions much like peanut butter, whereby that bolus is not lubricated enough just with your secretions, and so it has a propensity to not have the necessary moisture to glide down the pharyngeal tract. Hard fruits like apples and pears, as well as hard candy and candy with large nuts, carry the same risk. So what's your response? What's the expectation? If someone chokes, your job is to provide emergency first aid, abdominal thrust, call 911 if the person's airway is blocked and they can't breathe, administer CPR as appropriate. Emergency services will stay on the phone. They will guide you through that process if necessary. It will require a village. Someone else will be contacting the nurse at that same time. And if not, then you'll make sure you follow up with the nurse post-incident. And you'll be sure to follow individual specific instructions per the person-centered plan. How do we prepare for a choking event? The National Safety Council's airway obstruction and choking video is a good way to prepare for that. In addition, your agency should strongly consider mock choking drills along with other safety drills to prepare yourself.
Choking is a common emergency. In adults, choking usually happens while eating, and with children, while they're eating or playing. If the person is coughing and trying to expel the item on their own, don't interrupt.
Point of importance there. If the person is able and breathing to actively try to manage the situation, the instruction is let them be until they are clearly in distress and their airway is blocked. They give the universal sign of choking, or they indicate visually, gesturally, that they're in need of support.
But if the person is in clear distress, clutches their throat, looks frantic, or signals that they're not getting enough air, then it's time to give first aid. Let's take the basic technique step by step. First thing, ask, are you choking?
Are you choking?
If the person cannot cough, speak, or breathe, quickly ask for consent to give first aid and have someone call 911.
Can I help you?
1. Stand behind the person with one leg forward between their legs to brace yourself. 2. Locate the person's navel with a finger from one hand. 3. Make a fist with the other hand and place the thumb side of the fist against the person's abdomen just above the navel. 4. Grasp your fist with your other hand and thrust inward and upward into the abdomen with a quick motion. 5. Keep performing thrusts until the person expels the object or becomes unresponsive. If the person you need to help is someone you can't get your arms around or is pregnant, or when you can't effectively give abdominal thrusts, you can perform chest thrusts on the middle of the breastbone from behind the person. Take care not to squeeze their ribs with your arms. A person who is choking is not breathing and may soon become unresponsive.
Hey, are you okay?
Have someone call 911
Call
immediately.
911 and get an AED.
Lower the unresponsive person to the ground and start CPR by pumping the chest 30 times hard and fast, followed by 2 breaths. Before giving breaths, check the mouth and remove any object seen.
You have now come to the end of the prerequisite first part of the Choking and Dysphagia Train the Trainer course. Please complete the knowledge check quiz at your own pace. You will receive a certificate of completion, which is required in order to register for the second part, the in-person training, which upon completion you will be certified to train others at your agency. Thank you.